Hi, good evening, everyone, and welcome to our Facebook Live session. 365 Live is a platform where we educate the public about cancer and promote cancer prevention lifestyle. Therefore, when you see this logo, it means that 365 Cancer Prevention Society is having a live podcast. My name is Sarah, and I'll be the host for tonight. This talk is specially brought to you by 365 Cancer Prevention Society and our esteemed medical partner, Specialized Therapeutics. For a short introduction of our society, 365 Cancer Prevention Society was founded in 2003 as a social service agency with IPC status, and we are a full-fledged member of the NCSS. The society mission is to serve the community through holistic cancer prevention measures, and this is accomplished through health and nutrition education, promotion of healthy lifestyle, as well as our lymphatic detox exercises. We also provide practical and emotional support for our members as well as their family members in their cancer journey through our residential and hospital visitations, counseling, nutrition consultations, and wellness services. Therefore, I encourage everyone here to like and share our comment on our social media pages for the latest update on our events and activities. Before we begin our talk, to ensure that all the information that is shared at this event by the speaker and 365 Cancer Prevention Society are for general information only and subjected to changes. Do consult your doctor for personalized and detailed medical advice. Thank you. Next. Before we begin, I'd like to introduce a campaign by 365 Cancer Prevention Society called My First Memo. As I believe a lot of you know, breast cancer is one of the most common cancers in Singapore. Therefore, 365 Cancer Prevention Society launched My First Memo campaign with an aim to help women aged 40 and above from lower income households to receive a sponsored mammogram screening, which includes a pre and post consultation. This mammogram screening will allow for early detection of breast cancer and early treatment. The donation tiers starts from $30 and can go up to $100. To support this campaign, you can either scan the QR code or click on the URL link. I'll give everyone a few moments to do so. And I do encourage everyone to donate generously, as your donation will go a long way to help someone like a daughter, a mother, or even a caregiver around you to receive the treatment and support that they need. Next. And not to forget, a special thank you to our sponsor, Icon Cancer Center, and our supporting partners, Satacom Health and Early Medical Center, for making the mammogram screening possible. Next. Tonight's topic is on the hope on the horizon of advanced breast cancer. Our speaker for tonight is Dr. Lynette Knorr from Curie Oncology. Dr. Knorr is a medical oncologist who specializes in women's cancer. So now, without further ado, let's welcome Dr. Knorr.
Hi, Sarah.
Yeah, hi, Dr. Knorr. Nice to
Hi.
have you here tonight. Yeah,
Thank
hi.
you.
Yeah, thank you very much for joining us tonight. And I will hand over the time to you now.
Thank Okay, hi everybody, and thank you so much for sharing your very precious weekend with us. Today, I hope to share with you more about advances in breast cancer treatment in a very challenging set of breast cancers, the stage 4 advanced breast cancer. So I'll now proceed to share my screen. Okay, so I'm Dr. Lynette Ngo. I'm a medical oncologist in Curie Oncology. I graduated more than 20 years ago in 1996. At that time, when a woman is diagnosed to have breast cancer, it's often synonymous with a death sentence. However, I still found a great meaning in taking care of such patients because we walk the journey with them, we help them relieve their symptoms, we help to prolong their lives. But things eventually changed. When I started practicing oncology in 2005, things started to change. Treatments were more advanced, our patients could live longer, and more importantly, they can live well. So, this is one of my patients. She has a very difficult to treat type of breast cancer. It was a triple negative breast cancer, and she was diagnosed to have stage 4 at diagnosis. We were very close to her. We could relate with her because she was around our age. She was young and energetic and just about to embark on her career when she was diagnosed. We walked the journey with her and she fought a long, hard battle. She was very brave, but ultimately she succumbed to her cancer. Today, she could have received a new kind of treatment, immunotherapy, that has been discovered to be very effective in breast cancer. So in this day and age, there are much more treatments available. So the breakthroughs in breast cancer treatment will be the topic of our talk today. I'll explain what is breast cancer, what are the current treatments, and what are the new advances in breast cancer treatment. So what is cancer? This is a normal cell. When the cell develops mutation, either through environmental factors, genetic factors, or just by chance, they start to grow abnormally. And then they divide uncontrollably and they start to invade into the surrounding structures. They also go into the bloodstream and they start to spread to other organs. It can be the lung, the liver, or the brain. And we term this as stage 4 cancer. And if the cancer originates from the breast, then this would be an advanced breast cancer. So we usually define early breast cancer if the cancer is only confined in the breast, and if it has moved to other parts of the body, then we call it advanced breast cancer. So I'll go through the incidence of breast cancer, what are some of the current common treatments for advanced breast cancer, and what are the new breakthroughs in breast cancer treatment. So as we all know, breast cancer is the most common cancer in women in Singapore and in all over the world. It comprises almost 1/3 of all cancers diagnosed every year in women. This is a geographical representation of the incidence of breast cancers in Asia. The countries that are colored darker in blue have the highest incidence, and this includes Japan, Korea, the Middle Eastern countries. And when we look at Southeast Asia, Singapore is the darkest blue. Singapore has the highest incidence. And why is this? Partly it's because Singaporeans have adopted a westernized kind of diet. Our diet tends to be higher in processed food, higher in fats and cholesterol. On top of that, our Singaporean women are all career women, and oftentimes they don't have time to juggle both work and family commitments. So families are smaller, they have fewer children, they don't have much time to breastfeed, and sometimes they don't even have time to go for screening mammograms and ultrasounds. If you look at the incidence of breast cancer in Singapore over the past 50 years, from the 70s to current age in the blue line, you'll notice that the incidence of breast cancer has been slowly increasing over the years. Thankfully, when you look at the death rate from breast cancer, it has remained flat. This is thanks to the advances in breast cancer treatment. So how do we treat breast cancer? So in the past, because the cancer has spread to any other organ, for stage 4 breast cancer, the main treatment is systemic treatment, meaning we administer treatment into the veins it would circulate around the whole body and treat cancer in any part of the body. So that's called systemic treatment. In the past, it used to be a one-size-fits-all. Any woman who is diagnosed to have advanced breast cancer would receive chemotherapy. However, we found that not all women responded equally and not all cancers behave the same way. When we look under a microscope, we realize that breast cancer is not just one disease, but it's actually heterogeneous. It's different types of disease. Some breast cancers stain positive for estrogen receptor. Some breast cancers stain positive for a protein called HER2. And some breast cancers don't stain for anything at all. We call that triple negative breast cancers. So when you look at breast cancer, we realize that there are actually three main subtypes of breast cancers. So the most common one is hormone receptor positive breast cancers, and they comprise 60% of all breast cancers. These cancers are very sensitive to female hormone estrogen, and estrogen stimulates the cancers to grow. It's like a food for the cancer. Another 20% of breast cancers have a protein called HER2, and we call that HER2 positive breast cancers. And the least common, 15 to 18%, are what we call triple negative breast cancers. Unfortunately, these are also the most aggressive types of breast cancers. They tend to recur very easily and they tend to spread to other organs. And we realized that knowing the different breast cancer subtypes would helps us to treat them differently as well. So let's look at each subtype of breast cancer. So the hormone receptor positive breast cancers, we realize that it's the female hormones that stimulate these breast cancers. When estrogen binds to estrogen receptor and progesterone binds to progesterone receptors in the cancer cells, that stimulates the cancer to grow and divide. So the strategy for treating these cancers is to deprive the cancer of female hormones. So estrogen would bind to the estrogen receptor, forming an estrogen receptor complex, and then it would stimulate the cancer to grow. So we could either reduce estrogen or we could prevent the estrogen from binding onto the receptor. So again, estrogen binds to the estrogen receptor, causes the cancer cells to grow. One of the oldest and the most well-known drugs for estrogen receptor positive cancers is a drug called tamoxifen. It basically binds to the estrogen receptor. When it binds to the estrogen receptor, it deprives the estrogen of binding to that receptor and stimulating it. So it kind of sits on the estrogen receptor, and that prevents the cancers from growing. So if the cancer cells have estrogen receptors, then tamoxifen would work. If they don't have estrogen receptor, then tamoxifen doesn't work. For the second type of breast cancer, the HER2 positive breast cancers, they found that these cancer cells actually have many HER2s. So normal cancer cells have a few HER2 proteins, but the HER2 positive breast cancers have a lot of HER2 protein. And they found that the HER2 proteins are what makes the cancer cells divide and grow very quickly. So the approach to treating HER2 positive breast cancers is to block the HER2 from being stimulated. So again, one of the oldest and one of the most well-known drugs are Herceptin or trastuzumab. This is a targeted therapy against HER2. So the drug Herceptin binds to the HER2. It prevents the HER2 from stimulating the growth of the cancer cells and then prevents it from dividing, and that's how the Herceptin works. And lastly, triple negative breast cancers. Unfortunately, because triple negative breast cancers don't have estrogen receptor or HER2 receptors, they don't have any receptors at all. So the only treatment that is available for triple negative breast cancers is chemotherapy. Therefore, the prognosis sometimes is not very good. So what are some of the advances in breast cancer treatment? Let's talk about the hormone receptor positive cancers. So we heard earlier that the main treatment for hormone receptor positive breast cancers is to reduce the hormone levels, reduce estrogen, or prevent the estrogen from binding to the estrogen receptors. So when we give a drug like tamoxifen, we actually see the cancer cells shrinking and reducing in size. The cancers in any other part of the organs will also shrink and reduce in size. However, this drug seems to only work for 1 to 1.5 years. Cancer cells are very clever. After a while, the cancer becomes very smart. They develop resistance to the hormone medication. So we need to think of a way to overcome this hormone resistance. So recently, they developed targeted therapies for the treatment of hormone receptor positive breast cancers. And one of this targeted therapy is what we call CDK4/6 inhibitors. These drugs inhibit the cell cycle and inhibit the cells from becoming resistant to the hormone treatment. And currently, there are 3 commercially available in the world: palbociclib, ribociclib, abemaciclib. And when we give these drugs together with the hormone drugs, we've seen the cancer responding for 2 years, 3 years, and beyond. And the results have been excellent. So one of these drugs, palbociclib, we see that initially, if they were just on hormone treatment alone, the cancer is kept in control for 14.5 months. If we add on palbociclib to the hormone drug, the cancer remains under control for more than 2 years. So the results are excellent. In fact, one of the drugs, ribociclib, has been also shown to improve the survival of patients, and at 4 years, 70% of patients remain alive. So that's excellent results compared to in the past when they only had 1 to 2 years to live. Now, we spoke about overcoming resistance. So if we deprive the cancer cells in the hormone receptor positive cancer cells of estrogen, we basically block the estrogen stimulation pathway. However, we found that these cancer cells, because they became smart, they develop other pathways of growing without the need for estrogen. So one of these pathways is the PI3K AKT mTOR pathway. Thankfully, nowadays we have developed inhibitors of the new pathway. So there's an mTOR inhibitor called everolimus, a PIK3CA inhibitor called alpelisib. There's also a new AKT inhibitor that is going to be made available soon. So there are many, many new drugs that help to overcome that resistance to the hormone treatment. So one of these drugs, the mTOR inhibitor, everolimus, has been shown to improve survival, and that has very good results. Let's shift gears to the HER2 positive advanced breast cancer. We heard earlier that what we use to treat HER2 positive breast cancers is a targeted treatment called Herceptin. So Herceptin binds on to the HER2 and prevents the cancer cells from proliferating. However, the response sometimes is not very good. So if one HER2 targeted drug works, maybe 2 HER2 targeted drugs will work better. So they developed a second HER2 targeted drug called pertuzumab. And when they bind onto the HER2, so trastuzumab is Herceptin, and pertuzumab is a second HER2 drug. If there are 2 drugs binding onto HER2, we find that the response rate is much better. The survival is much better as well. So in the Cleopatra trial, we found that patients with stage 4 advanced breast cancer, in the past, with just 1 HER2 drug, they lived for 4 years. With 2 HER2 drugs, they can live for almost up to 6 years. And that's incredible because it's just with one treatment. And when they fail this treatment and the cancer starts to grow, then more HER2 targeted drugs are made available. So there are another kind of drugs called antibody drug conjugates, and this is a very clever invention. So the antibody drug conjugate is actually a HER2 targeted drug and chemotherapy combined together in one single compound. So we have Herceptin, which is what we used previously for HER2 binding, and there's a chemotherapy drug that is joined to the Herceptin. And the good thing about this is that because the HER2 targeted drug would zoom in onto the HER2 in the cancer cells, and then when the HER2 targeted drug is bound to the HER2 receptor, the whole compound is absorbed into the cell. And then the chemotherapy is released into the cell. So the chemotherapy is only released within the HER2 cancer cells and not outside. Because of that, the side effects are so much less. So they don't lose their hair, they don't have nausea, vomiting. And one of these drugs is called Kadcyla or TDM1. And lately, they've even developed a second antibody drug conjugate. It's called trastuzumab deruxtecan or Enhertu, and the results have been excellent. This chemotherapy drug is 8 times more potent than Kadcyla, and the binding of HER2 is much better as well. On top of that, they started to develop HER2 targeted drugs that are very small in molecules. One of the problems with HER2 positive breast cancers is that the cancers tend to go into the brain and hide there. Chemotherapy works very well. The HER2 targeted drugs work very well to kill the cancer cells in the body, but they somehow cannot reach the brain to kill the cancer cells there. Therefore, brain spread to the brain or brain metastasis is very common in HER2 positive breast cancers. One of these amazing drugs is tucatinib. It's a small molecule that can cross the blood-brain barrier. So it crosses the plasma membrane into the interior of the cell and binds it there, it targets it there. So because of that, tucatinib has been shown to be very effective in treating cancer in the brain, even without any other treatment like radiotherapy. So the advances in breast cancer treatment has really jumped in the past few years. And what about triple negative breast cancers? As we heard earlier, the mainstay of treatment is still chemotherapy. And chemotherapy's response, the duration of treatment, the duration of the response is not that good. So prognosis has been relatively poor. In the past few years, scientists have developed a new type of treatment called immunotherapy. And that is thanks to these two individuals, Dr. P. Allison as well as Dr. Takasu. So what happens is that they won the Nobel Prize in 2018 for discovering immunotherapy. Instead of using chemotherapy to kill the cancer cells, they realized that they can actually use our own immune system to kill the cancer cells. So for patients with advanced breast cancers, the immune system are not able to recognize the cancer cells as foreign. Somehow there is a brake that is applied to the immune system so that they cannot recognize the cancer cells. And administering these immunotherapy, they would basically release the brakes from the immune system so that the immune system can be activated to kill the cancer cells. And the results have been excellent. And not only that, they also found that triple negative breast cancers, 40% of triple negative breast cancers are associated with genetic mutations. And individuals with a gene mutation, such as BRCA mutation, they found that they are very sensitive to a targeted drug called a PARP inhibitor. So these patients have more than just chemotherapy. They have option of immunotherapy as well as targeted treatment if they qualify for it, if they have a BRCA mutation. So nowadays, more and more drugs are made available to them. And the results of PARP inhibitors for triple negative advanced breast cancers have been excellent. Again, with deciding on any treatment, we always want to weigh the benefits and the risks. So if a particular drug has a lot of side effects, the cost is very high, then it may not be worthwhile. However, if the side effects are very minimal with all the newer treatments and the benefit is very good, then we would proceed with that drug. So this brings me to the end of my talk. In summary, we know that breast cancer is the top cancer in women worldwide. The incidence in Singapore is still continuing. 1 in 13 women in Singapore will be diagnosed with breast cancer. Thankfully, mortality or death from breast cancer remains low thanks to advances in breast cancer treatment. but we know that it's not all one size fits all. We need to tailor our treatment according to the type of breast cancer. So if we understand the biology of the breast cancer, we know what are the latest advances in treatment options, and we can enable us to tailor the best treatment for the best outcome. And so with that, I thank you. This is the group that I work with. Each of us subspecialize in a particular area of cancer. And my email is over here. So please feel free to contact me or drop me a line if you have any comments or if you have any questions that you want to answer in private. Okay, thank you very much. This brings me to the end of my talk. Sarah, I will pass over the mic to you. Thank you.
Hi, thank you, Dr. Na. Thank you for comprehensive sharing. And now, let's see whether there's any questions from the floor. Okay. Okay, so while waiting for the questions to come in, let's ask the first question. So, Dr. Na, can I just check with you, is dairy milk consumption linked to breast cancer?
Okay, there have been a lot of patients actually ask me whether it's safe to take dairy. The reason why a lot of people worry about dairy products is because cow's milk contains estrogen as well. It contains hormones. But so far, it's not been proven that the hormones from animals stimulate or increase the risk of breast cancer. Of course, we don't want to put ourselves at risk, so we don't want to take as much dairy, too much dairy, but a little bit is actually good. The problem with dairy product is actually the fats contents. So dairy products actually have a high in fats, and that basically is the building block of estrogen in our own body. So the higher the fat content, the higher the risk for breast cancer. So if we want to take dairy milk, it would be good to take non-fat milk or low-fat milk rather than full cream milk.
Okay, sure. Thank you, Dr. Na. Right. And how about this? Because just wondering, how can a healthy diet help to prevent breast cancer?
So we know that there are many causes for breast cancer. Uh, Part of it is actually environmental. So you are right, a healthy diet, lifestyle, exercise, all these are important. But some of the causes of breast cancers include genetic mutations that there's nothing much we can do about, or radiation, or even occurring by chance. But what we can do within our own control is to control the risk factors that is within our power to control. So a healthy diet and exercise is always important. In fact, a Mediterranean diet that are high in vegetables, fibers, whole wheat, grains have been shown to reduce the risk of breast cancers.
Okay, sure. Thank you, Dr. Na. Alright, so there's a question from one of the audience. So I'm now on a hormonal therapy. May I know which group of people is suitable for immunotherapy?
Yep. So earlier we mentioned that there are three main types of breast cancers: the estrogen receptor positive ones, the HER2 positive, and the triple negative. So far, immunotherapy has only been shown to work in the triple negative breast cancers, and only a particular subtype of triple negative breast cancers. We need to do a staining to know whether this individual would respond to immunotherapy. For the hormone therapy group of patients, usually we find that the main cause of the breast cancer is hormones. So we want to reduce the hormones, and the treatments, the newer drugs that are available for treating hormone receptor positive breast cancers are the drugs that will prevent resistance to hormonal therapy. So the targeted treatments we were talking about.
Sure, thank you, Dr. Na. Yeah. Is there any questions? So feel free, to post your questions in the chat box. Maybe Dr. Na, there's also another question. I'm just wondering, can endometriosis increase the chances of having cancer?
Okay, so endometriosis has been linked to a certain type of ovary cancer called clear cell ovary cancer, not so much breast cancer. But the risk of endometriosis causing cancer is about 1 to 2%. It's pretty low, and usually is the risk is higher in postmenopausal women. Basically, endometriosis is when the um, the cells from the uterus um, seems to be implanted to organs that are outside the uterus, and this often causes a lot of inflammation. And we have when there is a lot of inflammation going on, this sometimes lead to mutations and leads to cancer development. So usually it's ovary cancer that we worry more about rather than breast cancer.
I see. Okay, sure. Thank you, Dr. Ma. Okay, there's actually one question from one of the participants. So is being cut product same as milk product?
Uh, so so they're all they all have the same worry or the same concern that they all contain hormones. So beancurd is a phytoestrogen, so it's a plant-based estrogen. Dairy product is animal estrogen. I would say plant-based estrogen has not been shown to increase the risk for breast cancer. They've done studies and they found that beancurd doesn't increase the risk. Um, I would say animal estrogen may be a little bit more risky than plant-based estrogen, but ultimately, it's our own body's estrogen it has been shown to stimulate breast cancer. So we want to reduce the estrogen levels in our own body, which is increased by again fats and cholesterol.
Sure. Thank you, Dr. Ma. I hope they answer your question. And now there's also another question from Janet Hing. So immunotherapy available in government hospitals?
Yes, it is. I think our government hospitals are as good as in private hospitals. They do have a lot of these drugs. So any drug that has been proven to prolong survival, that has been proven to improve outcome, they are all made available. But because the government subsidizes proportion of the drugs, so I'm not sure how much would be covered in terms of subsidies, but it is definitely available.
Sure. Yeah, thank you, Dr. Ma. And I hope the answers your question, Janet. Right, so we're waiting for other questions to come in. Perhaps I can ask another question, Dr. Ma. Right, so um, how can I lower the chances of having cervical cancer?
Cervical cancers.
Survival, correct.
Okay. So cervical cancers are different from breast cancer. Cervical cancers are actually caused by a virus rather than lifestyle or diet or gene mutations. So cervical cancer, 99% of cervical cancer is actually caused by a virus called human papilloma virus, HPV virus. And thankfully nowadays we can actually prevent this virus. So two ways in reducing cervical cancers. One would be doing regular screening. So we usually can do pap smear. Nowadays, we can even do DNA testing for the HPV itself. So doing screening helps us to discover the presence of the virus or the presence of abnormal cells. And so we can treat it when it's at the very, very early stage or the pre-cancer stage. The other way to prevent cervical cancer is actually with vaccinations, because now we realize that cervical cancer is caused by HPV. They have developed a vaccine against HPV. So if we do the injection um, 3 times, just 3 injections, that would give you a lifelong protection against developing HPV. And if you don't have the virus, then the chance of developing cervical cancer is very low.
Thank you. And there's one question from Valerie. I understand one of the side effects of taking the I hope I pronounce it correctly, tamoxifen, yeah, is increasing the risk of endometrial cancer. What will happen if one decided to take the is what's taken it?
So tamoxifen is used in early breast cancers to prevent breast cancer recurrence. In advanced breast cancer is used for treatment. So it is it is very effective in preventing breast cancer. So obviously, if we stop taking the tamoxifen, then that risk might increase. The risk of endometrial cancer with tamoxifen is actually pretty low if one does regular gynecology screening. So we usually get our patients to see a gynecologist or at least do an ultrasound scan of the pelvis to make sure that there are no abnormalities. As soon as we see some abnormality, we should stop the tamoxifen and switch to an alternative. And there are alternatives that are available. So better than stop it altogether. Maybe the other thing you can consider is looking at one of the alternative medications.
Thank you. Okay, there's another question from Janet Wing. So what is the success rate of immunotherapy for cancer with three negative receptors?
So immunotherapy is not 100% success rate, and not every triple negative breast cancer will respond to immunotherapy. But the good thing about immunotherapy is that once a patient responds to immunotherapy, that response can be very, very durable, can be for many, many years. And sometimes, even with advanced cancers, patients can get cured. So that's the hope. And we usually run some markers on the breast cancer. So usually we would do some staining, and that staining would tell us the chances of response to the immunotherapy. And if the stain is positive, then we would recommend immunotherapy, because then the chance of response would be pretty good.
Okay, thank you, Dr. Long.
Ah,
I
are
think
we
that's
not?
yes.
Uh, there was a question about grapefruit and pomelo when taking hormone targeted therapy. So it's mainly grapefruit, but pomelo also has a little bit of the same properties. So what happens is that grapefruit stimulates enzyme in the liver to break down the drug and makes the drug ineffective, which is why anyone who's taking tamoxifen or one of the targeted treatments, we usually advise them not to take grapefruit, because that can reduce the effectiveness of the drug. But if you take like one or two, I don't think it makes a big difference. It's more if you take it on a regular basis in larger amounts.
Thank you. So keep your questions coming in. Right? And perhaps I can ask a question though. There's actually a question over here. What are some of the side effects of immunotherapy, and how can we? Is there any food that we should avoid as well?
Radiotherapy.
Sorry.
Um, I sorry,
Okay. So
I didn't catch that.
okay. So are there any side effects of immunotherapy? And what kind of food should be avoided as well?
Okay. Side effects of immunotherapy. So the side effects of immunotherapy are very different from chemotherapy. We are commonly quite familiar with chemotherapy side effects. Patients are nauseated, they're very tired, they lose their hair, and generally immunotherapy they don't cause all these side effects. But immunotherapy side effects are caused by overstimulation or overactivation of the immune system. So if our immune system is overactivated, sometimes it can turn around and attack our good cells. So it can cause a lot of inflammation. So some people develop inflammation in the lungs, they may get cough or breathlessness. That's quite rare. More commonly, they get inflammation in the skin. So some people get rashes, or inflammation in the intestines, so they get diarrhea. Or sometimes it can also cause inflammation in the hormone glands. So sometimes they have reduction in the hormone levels of thyroid or even cortisol. So the side effects are a little bit different. Oftentimes the doctors will have to keep monitoring for these side effects by running tests and monitoring them.
Thank you. There's a question from the chat. It's from Ellen. How about taking turmeric tea? Would that reduce the effectiveness of amoxicillin? Amoxicillin,
Hmm.
sorry.
I think there were some small studies that actually showed that turmeric may reduce the effectiveness of tamoxifen. Um, all these are quite small studies. I think if you take it as a, not on a regular basis, so you don't take like a one big cup every day. If you just take it on and off once a week or so, once a month, then I don't think it makes a very big difference. So it's more the accumulative effect.
Mm, okay, thank you. Okay, so there's also a question. Is it encouraged to go for TCM treatment when on hormonal therapy?
Good question. So the problem is our livers are the ones that break down all these drugs. So our livers are working very hard to break down the hormonal treatment. And on top of that, if we take TCM, it might also continue to break down the TCM as well. So sometimes the liver, when it's overworked, the liver enzymes would go up. They get a lot of liver inflammation. So it's more monitoring whether the liver is coping well with all these supplements and drugs together. On top of that, because Chinese medicine and Western medicine, sometimes what we know about this medicine is based on studies. And sometimes the Western medicine, like tamoxifen, they have not been tested against the Chinese medicine. So we don't know whether the effectiveness of tamoxifen will be reduced by the TCM. But um, I yeah, so we wouldn't know. We wouldn't know. I mean, we are taking a small risk, but I think it's more important to monitor the liver function if you're on TCM.
Hmm, okay. Right. So there's also, sorry, I think I missed a question earlier from Lim Yi Fong. So when one is sorry, when is one in remission after breast cancer one side mastectomy treatment, HER2 positive 2B and last October after 1 year?
We in remission. We usually, if there's no cancer that is seen in the body from scans, generally we consider them to be in remission. But we want a durable remission. So we hope that a person would be in remission for more than 5 years. And generally, that risk of cancer recurrence would be much, much less.
Okay, can thank you. Right. And while waiting for other questions to come in, perhaps I can ask another question, right? Um, so one of the question would be like, uh, what if the mom actually has a breast cancer, and is it recommended for a daughter to go for a mammogram as well?
Okay. It depends on whether there is, so if the mom has breast cancer and the daughter has no breast cancer, it depends on whether there is any other family history of breast cancer. If the mom, the aunt, the cousin, many family members have breast cancer, then sometimes this can be a genetic risk. If there is a genetic mutation, then we will want to screen the patients much earlier. So we would start screening at 30 years of age. We would want to do MRI scan rather than just a regular mammogram. But we only do that if there is a genetic mutation. So usually we would encourage patients to go for genetic counseling and genetic testing if there's a very strong family history. But if mom has is the only person in the family who has breast cancer, then we would still continue regular screening, and that means yearly mammograms and ultrasound breasts from 40 years of age. We usually take 10 years before mom's diagnosis as a cutoff, as a rule, as to when to start breast cancer screening. We would usually take the time when mom was diagnosed minus 10 years.
Mhm. Okay, sure. Thank you. Right. Okay, so there's also another question. Is there cancer marker for breast cancer?
There are, but the breast cancer has to have not all breast cancers will secrete the particular substance that can be measured as a cancer marker. And usually we see cancer markers being elevated in very advanced breast cancer and stage 4 breast cancer. So at very early breast cancer, then these cancer markers may not be so useful in monitoring the cancer because a lot of the times it's all negative. So yes, there are cancer markers, but they may not be very specific and they may not be very sensitive as well.
Hmm. Okay, thank you. So there's also another question. Is ribociclib cause kidney and liver disease?
Mm. Well, yeah, so ribociclib is one of the targeted treatments for hormone receptor positive breast cancer. Is in the group of targeted drugs that prevent resistance. So the CDK4/6 inhibitor. Ribociclib is a very good drug, but it does have side effects. So one of the more common side effects is actually it can cause liver inflammation. It can cause the liver enzymes to go up. If it causes the liver enzymes to go up a little bit, we sometimes continue the medication with a reduction in the dose. But if it causes the liver enzymes to go up very, very significantly, then we might have to stop or change to a different drug. Ribociclib sometimes also causes the kidney function, the what we call the creatinine, to go up. But usually this doesn't it doesn't result in kidney failure. So usually if there is a slightly elevated creatinine level, we still continue the drug because it's a function of this drug.
Mm, okay, thank you. Right, so there's also another question. What are the chances of relapse of breast cancer?
The chances of relapse are dependent on a lot of factors. So one is it depends on which stage. The higher the stage, the higher the chance of relapse. It also depends on the subtype of breast cancer. So we were talking about the three main subtypes. The chances of relapse in HER2 positive and triple negative would be much higher than the ER or the hormone receptor positive breast cancers. And finally, it also depends on whether the recommended treatment has been completed or not, because some patients get a lot of side effects. They decide that they don't want to continue the treatment anymore. Then the chances of relapse can be higher. So it really depends on a lot of these factors as well.
Mm, okay, sure. I think Lim Yi actually replied. So she mentioned that her doctor said that hers is local yet aggressive and removed 23 lymph nodes instead of the one which is magnesium.
Um, yep. So when we're talking about early breast cancers, so my talk earlier was on advanced breast cancer or stage 4 breast cancer. So the treatment is mainly more lifelong, mainly to keep the cancer under control so that the cancer doesn't cause problems for as long as possible. For early breast cancer, the treatment approach is very much different. It's more to prevent relapse. So we don't want the cancer to come back again. So sometimes we look at some risk factors for the cancer to come back again. Like I mentioned earlier, it depends on the stage, it depends on the type of cancer, whether it's HER2 or triple negative. And then we would usually use particular treatments or recommend certain treatments to try and prevent the cancer from relapsing. So if the cancer is local and aggressive, but you have received all the necessary treatment like chemotherapy, then I think that would have significantly reduced your risk. You have already done a lot to reduce that risk already.
Okay, thank you. Um, do keep your questions coming in. And perhaps I can ask also another question. How accurate is the BRCA gene test in identifying the potential of breast cancer?
Hmm. So the BRCA gene mutation is an inherited gene mutation that makes an individual more prone to getting cancer. If anyone has a BRCA gene mutation, you have up to 80% chance of developing breast cancer. as well as 40% chance of developing ovary cancer. So it increases the cancer risk. But it's not just the BRCA gene. Nowadays, we've discovered there are a lot of other kinds of gene mutations that can also increase the breast cancer risk. So some of these gene mutations may not increase the risk of breast cancer up to 80% like BRCA. It could only increase to maybe 50% or 30%. There's a moderate risk. So we wouldn't know unless we test. So anyone who has a strong family history or who is very young when you develop breast cancer, which is unusual, then we usually would recommend genetic testing. And then you will know once and for all if you have a gene mutation and whether your risk is higher than usual or not.
Right. So, okay, there's one more question. What's the minimum recommended duration for hormonal therapy for it to be effective? So, if cut short, will it be considered as non-effective?
Minimum, I would say 5 years, because all along, all the studies have used 5 years of treatment. Recently, they have actually looked at 10 years of treatment, and they found that it still continued to prevent breast cancer if we continued the drugs for 10 years. There was another more recent studies where they looked at 7 years of treatment, and they found that 7 years of treatment is as good as 10 years. So I would say if there is a low risk of breast cancer, if you have early breast cancer, then 5 years would be good enough. It's a minimum. But if you have a slightly higher risk of breast cancer, then I would aim for at least 7 years.
Okay, thank you. Okay, another question is, how do I know if there's a growth in my brain due to breast cancer?
We usually need to do a scan. We usually do an MRI scan of the brain. So that will tell us if there's anything in the brain. And for patients with HER2 positive breast cancers, because cancer in the brain is very common, anyone who has headaches or any other symptoms, we should quickly scan the brain.
Okay, right. Okay, so another question from Ling Yifeng. Is it common for discomfort pain on lymph nodes underarm near the operated breast? How else can we reduce the inflammation?
Well, we firstly want to make sure it's only okay. So surgery causes a lot of scarring, and scarring can sometimes cause pain. It's just that we need to make sure it's not anything more serious or sinister like cancer recurrence. So usually the surgeon would check the area for lumps or do an ultrasound to make sure it's nothing else. But if they do the ultrasound and everything is clear, then most likely it's caused by the surgery. And it's quite common actually.
Okay, I think we can wrap up our session with one last question over here. This is from Janet Hing. If immunotherapy is successful for cancer with three negative receptors, is there a need for chemotherapy after that?
So usually we give chemotherapy and immunotherapy together, and once chemotherapy is completed, we will continue the immunotherapy alone. And if it is successful and there's no the cancer is reduced, and it's not growing anymore, then we don't have to restart the chemotherapy. We will keep going with the immunotherapy. And in some lucky individuals who respond very well to immunotherapy, we can actually even consider extending the time between each immunotherapy cycle. And some of my patients even manage to stop the immunotherapy altogether, which means that the cancer is already stable. So yeah, if you respond well to immunotherapy, that's the best outcome.
Okay, thank you, Dr. Nor. And thank you everyone for your questions tonight. And thank you, Dr. Nor, for sharing and answering all the questions. Yeah, so once again, thank you very much. Okay, so at this point, we would appreciate if you could help to fill up the feedback form for tonight's talk. Do scan the QR code on the screen with your mobile device, or you can also click on the URL link. Give us your feedback for tonight's talk. Our next Facebook Live will be on head and neck cancer. It will be on the 29th of April, 8:30 p.m. on the same platform, which is a Facebook. Do follow our social media pages for more updates on this talk. Once again, do like and share our social media pages for the latest update on our events. Thank you very much for joining us tonight, and we hope to see you in the next talk. Take care and good night.